IBS-D. And so they thought maybe he has endocarditis. So he got an echocardiogram, which showed giant coronary aneurysms with normal LV function. So that is how he got diagnosed. When you have this cognitive bias, you think you know what you know, and it just was not crossing anybody's mind. So he was admitted to the hospital, got IVIG and aspirin, got methylprednisolone and IV heparin as well because of the concern of how big the coronary aneurysm was. He continued to not improve, got infliximab, and eventually also he went home with enoxaparin and aspirin for the coronary and on a steroid taper, but he still has very large aneurysms. We don't know the mechanism of this disease. We are thinking, is there any hints we can get from what seems to be this delayed or hyperinflammatory response in adults that happens about 10 days after the acute infection? Is that a clue? When we look at the genetics of Kawasaki disease, all the genetics point to genes that actually regulate the production of T cells or an antibody response, or even the clearing of antibody and immune complexes. Are there any ways that we can predict which are the kids that are going to get aneurysms? Are there any markers? Mark Levin had mentioned, this is not published yet, I believe, but in the UK, when they looked at the patients with aneurysms versus without aneurysms, they could not distinguish any biomarkers to show which kids were going to get aneurysms. They looked at CRP, troponin, BNP, how febrile they were, the antibody levels, no markers, no way to tell, which is similar to Kawasaki disease in that the inflammatory markers don't actually tell you which kids are going to have the worst aneurysms. There's no way to predict a priori which are the kids that are going to be worse off. So I'm going to mention this, our last kid of this series that also happened in that 2-week time frame was an 8-year-old girl who came in with a history of 4 days of fever, diarrhea, abdominal pain, decreased appetite, but also with nocturia and polydipsia. And she had conjunctivitis for 1 day, just the day of admission. And her labs showed diabetic ketoacidosis, of all things, very high serum glucose, ketones in the urine. She also had a very high CRP, high SED rate, high white blood cell count, low lymphocyte count. And she was quite hypotensive. So on her echocardiogram, we also showed decreased left ventricular function and coronary artery dilatation. In her treatment, she got a lot of IVIG, a lot of IV fluids just for her blood pressure. And so, of course, very rapidly progressed to having significant systemic edema, pleural effusions, and even worse function, to the point that she was on very high doses of intravenous epinephrine, vasopressin. We added infliximab. She was still very sick. We eventually added steroids. And she got very quickly, she got much better. So it's hard for me still to understand if it was the steroids or it's just that things are just going to get better. It's still very confusing to me. So she got infliximab, still had bad function, very low blood pressure. We started the 5-day course of methylprednisolone, but after the second dose, completely normal blood pressure, weaned off all of her pressors, has completely normal function. The coronary artery is completely normal. She still has diabetes and she's home. So after all of this, the CDC here in the United States put up this definition for multisystem inflammatory syndrome in children. I wish they had stuck to our name of tums because it's easier to say. But anyway, and it matches exactly what the Royal College was defining, but very importantly, it added that there has to be evidence for infection. So it says that there has to be positive for current or recent infection, including serology or a history of exposure. And this is a little crazy because even in the United States, very, very many hospitals do not have access to serology testing and their administrators are giving them a hard time about checking. So I don't know how we're going to include these kids. And the antibodies could be evolving. The kids could be in that in-between stage where maybe their rectal swab is still positive for PCR, their antibodies aren't positive, maybe their IgM is positive, we don't really know. So, but however, this is how the CDC defined it. And then the WHO the next day defined it basically the same way. There's almost no difference between the WHO definition and the CDC definition, in that they require some evidence of positive serology. So at the end, just leaving us with these questions, but we can talk about this at the end. I think this is what the whole world is thinking about right now. The first most important question as pediatricians, we look at these kids that are a little febrile, a little bit of inflammatory markers, and then we have this other group of Kawasaki disease-like, and then we have the other group of shock. Do the patients progress from the less sick to the more sick? Can you actually change categories? Are they all actually connected? Can you tell which ones are going to progress? What is the risk even of coronary aneurysm in each group? Is it the same in every group? What is the relationship of the Kawasaki-like syndrome to the actual Kawasaki disease that we had before the pandemic? Is it the same mechanism? Can we learn from it? Do the anti-inflammatory and immune modulators that we are using based on our experience with Kawasaki, do they work? Do they protect the coronaries? Are the kids going to get better anyway? Does it make a difference? What is the pathophysiology of all of this? And of course, are there any biomarkers that are present to help to distinguish one group from another? Looking at just these 3 patients that I talked to, I tried to put a quick table together. And just mention the fact, as you can see, that the ages of the patients are completely different. 8-month-old, 3-year-old, 8-year-old. In other series, as you know, the kids can be teenagers or young adults. No particular gender or ethnic background. And this is again corroborated by the data from New York and Italy. They can have coexisting diagnoses that can be very confusing as you're trying to diagnose this febrile child. They tend to have a higher white blood cell count. The kids who had more shock maybe had more evidence of lymphopenia. They had high inflammatory markers. Really importantly, as you can see, the antibody levels did not seem to correlate at all with how sick the kids were. So this is also, I think they studied this at least on their few patients in England. So it's not official published data yet, but their impression yet is so far, some kids have very high antibodies and they have mild sort of Kawasaki syndrome, and some kids with shock do not have very high antibody levels. So that doesn't seem to be the relation. The echo findings can be very variable. You have pericardial effusion, some change in function, coronary artery problems, again, not correlating with the antibody levels or the inflammatory markers per se. And so this is, yeah, again, we don't really know which are the kids that are going to get aneurysms, but I tried to call all my friends that I could find around the world. Nobody has figured this out yet. All we can say is if they look like they have Kawasaki disease, they probably are going to have coronary involvement. Those who look like they have shock, probably about 20% might have coronary involvement. And we don't know anything still about those that we're not really studying, the ones with very mild illness, fever, and high inflammatory markers. So I'm going to end there. And I don't know how to stop sharing. I don't know if you can do that there. My arrow's not working, is it? Here it is. Oh, here we go. Nope, I can't. Thank you
very much. Thank you very much, Professor. It was a great presentation and it was very educational for us. I really enjoy your presentation, and I believe you are a referral center for Kawasaki in LA, yes?
Yes.
You have, I believe you have great experiences with coronary surgeries also in LA, yes? Coronary artery surgeries in pediatric group, yes? So it was a great honor to have your presentation with us. I believe there will be so many questions, but it's something very interesting in your cases. It was I believe, all 3 patients had a history of abdominal pain, and that is very interesting for me. And also, I would like to ask you, do you have any experience with these patients and with other other cardiac presentations, like myocarditis or valvular involvement or something like that?
Yeah, good thing that asking that. The 8-month-old patient and the 3-year-old patient and a couple other patients, since they have at least mild mitral regurgitation, the children with shock tend to have maybe mild to moderate mitral regurgitation. At first, I thought that was because of the volume overload, that we'd given them too much fluid, but their hearts are not dilated. So it's just decreased shortened fraction with mild to moderate MR. One of the more interesting things I noticed on echo, but we don't have enough patients yet to tell, is a couple of them had very dilated pulmonary arteries. So to be honest with you, I'm starting to think more and more, how much of this is going to be maybe, should we be looking more at polyarteritis nodosa? When we look at the features on echocardiogram of these patients, their coronary aneurysms don't look so typical for Kawasaki. You know how for Kawasaki disease, you can have a sort of like a skinny coronary, and then you have this big saccular aneurysm, and then it gets small again. A lot of these kids, the dilation starts at the aortic root. So it's already dilated as it comes, and then it gets a little fusiform, and then it stays big. And so all the coronaries are a little bit big. And it reminds me more of how the polyarteritis nodosa coronaries might look. And should we be looking at other, arteries in the body? Because we don't really know what causes the abdominal pain. Where is the vasculitis? Is it really only, localized to the coronary arteries? And in terms of myocarditis, I think that the kids who have decreased function, I believe it is on the basis of myocarditis. I'm sure it's not from cardiac insufficiency. So far, none of our kids have had an elevated troponin, even though you can have troponin elevated with myocarditis, but just no evidence of myocardial infarction in any of our patients. And the function improves very quickly. So I believe the function is because of inflammation.
So thank you very much. Now we can go. Now we can continue with our case presentation. First, let me just introduce our panelists here. First, we will have dear Dr. Fatemeh Tahqiqi. She's pediatric rheumatologist and assistant professor in TUMS. We will have dear Dr. Mehdi Zadeh with us, radiologist and associate professor in TUMS. We also have my dear friend, Dr. Kayhan Sayyadpour, pediatric cardiologist, also associate professor in Tehran University of Medical Sciences. We will have Dr. Pejman Rohani, pediatric gastroenterologist, assistant professor in Shahid Beheshti, University of Medical Sciences. Dear Dr. Behdad Gharib will be with us, pediatric intensivist and assistant professor in TUMS. We will have also dear Dr. Abdus Salehi, infectious disease specialist, assistant professor in Tehran University of Medical Sciences. Our case will be presented by Dr. Maryam Bakhtiari, one of our friends and one of our talented pediatric residents in Children Medical Center of Medical Sciences. And please start, Dr. Bakhtiari.
Okay. So, do you have my voice?
Yes, loud and clear.
So, good evening to everyone and good morning to Dr. Badran. We really enjoyed your presentation and your talk, and it was an honor to be here and to listen to your talk. Okay, so I'm Dr. Maryam Bakhtiari. I'm a second-year pediatric resident in Children Medical Center, Tehran University of Medical Sciences, and I have the honor to be here with you guys. So let me just start by sharing the slides of the patient. Okay, so the patient that we're going to talk about today is a 6-year-old boy with the chief complaint of fever, nausea, and vomiting, abdominal pain from 7 days prior to his first admission. He also complained of headaches, myalgia, and a dry cough, also from 7 days before. On his primary physical examination, he had bilateral non-purulent conjunctivitis and a generalized maculopapular rash. And he was admitted in another hospital, and because of his prolonged fever, a full sepsis workup was done, including a lumbar puncture, which the LP results were normal. Also, in considering the ongoing COVID-19 pandemic, a COVID-19 PCR was sent in that center, which was negative. One of the differential diagnoses that they had in
Dr.
mind.
Bakhtiari, I'm
Yes.
sorry, your slides are not running. They are just still in the, can you see that? They are not running. Please run your slides.
They're running for me. Okay, so. Okay, are they working now?
No, we can just see the first page of your slides. So you should go and run your slides. Yes.
Excuse me, Dr. Aghay. I think Dr. Bakhtiari must enable editing at the above of the slides.
Yes,
Okay,
of course,
okay,
yes.
okay.
Thank you very much.
Sorry I'm so sorry. Okay. Okay, so are they working now?
Yes.
Yes, okay. Okay, we're back on. So let me just review the patient again very quickly. A 6-year-old boy, fever, nausea, and vomiting and abdominal pain from 7 days ago, headaches, myalgia, and a dry cough. And on the primary physical examination, the patient had bilateral non-purulent conjunctivitis and a generalized maculopapular rash. He was admitted in another hospital. A full sepsis workup was done, including a lumbar puncture, which was normal. A COVID-19 PCR was sent in that center, which was also negative. Okay, so we were here. So one of the main differential diagnoses that they had in mind considering the prolonged fever was Kawasaki disease. So they did an echo, which showed aneurysmal changes in RCA, thus confirming the diagnosis. And the patient received IVIG with the impression of Kawasaki disease in that center. But due to continuation of fever after IVIG treatment, the patient was self-discharged against medical advice and referred to our hospital around 7 days from the beginning of his symptoms. On the admission in our center, the patient was still febrile, and the patient couldn't walk straight because of the severe abdominal pain that he had. The pain was relieved by bending and had no connection to food consumption or bowel movements. He still complained of the dry cough and the myalgia. The patient didn't have any significant past medical history, and there was no history of contact with anyone diagnosed with COVID-19 or anyone with any similar symptoms. Okay. So on the physical examination, the boy was awake, oriented, but he was deeply agitated. There was no respiratory distress. The vital signs were as follows, with the temperature of 38.5, a pulse rate of 106, blood pressure of 100/60, and respiratory rate of 30. The O2 saturations were 97%, which were normal. In the head and neck examination, I'm just going to point out the important ones and the positive ones. In the head and neck examinations, the patient still had the bilateral conjunctivitis. The patient had red cracked lips, but there was no strawberry tongue. No meningeal signs, no lymphadenopathy, but the rash was still there. The generalized maculopapular rash was still there. The heart and lung auscultations were normal. In the abdominal examination, the patient had generalized abdominal tenderness and a mild splenomegaly was noted. And in the extremities, the patient had swollen hand and feet without any skin peeling on fingertips, and the BCG injection site was normal. Okay, as you can see here, these are the lab results of the patient while on admission in our center. I've highlighted the important ones, the clues. So we will review them. The patient, the white blood cells were around 6,000 with absolute neutrophilic count of 4,300, an absolute lymphocytic count of around 1,200. So the patient was lymphopenic. This is a clue. The hemoglobin level was 10.6 and the platelets were around 141,000. The patient was thrombocytopenic. This was also important. The patient had high CRP and ESR levels, but the liver function tests were normal. The coagulation studies were normal. One of the differential diagnoses that we had in mind because of the abdominal pain was pancreatitis. So we checked lipase and amylase, and they were both significantly increased. The lipase were at the beginning, it was 208, which increased to 418. And the amylase was 98, which increased to 220, which are a lot high. The total protein level was 4.9 and the albumin was 2.8. So the albumin was low. This is important as well. And the calcium was 7.6, but considering the low albumin level, the corrected calcium will be around 8.5. The LDH was around 600, which was high, but the CPK was 54, which was normal. Just a minute. Okay, and the triglyceride was around 192, which was high, but the cholesterol was normal. The ferritin was increased, the procalcitonin was high, and the stool calprotectin was also increased. The urine analysis was done. The sample was taken from the midstream of the urine. This is important because of the Kawasaki diagnosis. The urine analysis had normal specific gravity, but the patient had sterile pyuria. The patient had white blood cells in the urine, but the urine culture was negative. And this is important as well. The blood culture obtained on the first day was negative, and also a COVID-19 PCR was sent again in our center, which was positive. Okay, so as we can see here, this is the chest X-ray of the patient. We will ask our professor, Dr. Mehdi Zadeh, to talk about the X-rays after this presentation.
Dear Dr. Bakhtiari, just wait a second. I would like to ask everybody to silence your microphones because it is an interfering noises with the presentation. Please silence your microphones right now. Okay, thank you very much. Please continue.
Okay, so I was saying that these are the X-rays of the patient. The previous one was the chest X-ray. This is the abdominal X-ray. And this is the abdominal CT scan, CAT scan, but we could see the lower cuts of the lung as well. So let me just play.
همکاران گفتونیه تو برو چیز کن بده من گوش کنم نیم ساعته میام در ببند نمیخونم نماز دارم گوش کن در ببند.
So should I continue?
Please continue.
Okay, so that was the HRC, that was the abdominal CT that we saw. Also, an abdominal pelvic ultrasound was done, which showed mild splenomegaly and a mild to moderate free fluid in pelvic cavities, but the ultrasound was otherwise normal. So these are the main things that we did for the patient. He was admitted. Definitely there were some IV hydration because of the diagnosis of pancreatitis. The patient received more than maintenance fluid. Also, there were some we gave the patient painkillers. There was some proton pump inhibitors like pantoprazole added to the regimen. Considering the COVID-19 PCR of the nasopharyngeal secretions, which was positive, we added hydroxychloroquine as well. We did another echocardiography in our center, which showed improved coronary involvement, but with the diagnosis of the Kawasaki and also having in mind that the fever was still continued during admission, the patient received another dose of IVIG, also aspirin. And because of the continuation of fever, even after the second dose of IVIG, the patient received high-dose methylprednisolone. So in summary, the patient was a 6-year-old boy with fever, nausea and vomiting, and abdominal pain, bilateral non-purulent conjunctivitis, generalized rash, dry cough, and headaches from 2 weeks before admission. The patient had aneurysmal RCA in the first echo compatible with the Kawasaki diagnosis and received IVIG, aspirin, and then high-dose methylprednisolone. The patient had abdominal pain and high amylase and lipase, which were compatible with the diagnosis of pancreatitis. And also the patient had positive COVID-19 PCR, which he received hydroxychloroquine for that. The patient was released from hospital after 7 days in good health with resolved fever and abdominal pain. He didn't require any ICU admission during his stay, and he was advised to do a follow-up after 2 weeks. Thank you for your attention. If there's any question, I will gladly be answering.
Thank you very much, dear Dr. Bakhtiari. Your presentation always is clear and good. Just because of the shortness of time, just let me ask our first panelist, Dr. Taqiqi. Dr. Taqiqi, are you agree that we can use the same criteria for the diagnosis of the Kawasaki disease with the typical form that we can see in our clinic and also in MISC? Can we use the same criteria for both diseases? And also, can you tell us from your experience, should we expect a severe form of coronary involvement with MISC?
Hi, everybody. Do you have my voice?
Yes, very clear.
Okay. I have to say, although children with MISC have symptoms similar to Kawasaki disease, they often show multiple inflammatory system involvement, sometimes leading to multi-organ failure and shock. And although the full spectrum of the disease is not yet clear, but it seems the symptoms of disease are more severe than Kawasaki disease. So there is a need for a collection of data describing clinical presentation, severity, outcomes, and epidemiology. This says WHO has developed a preliminary case definition for multi-system inflammatory disorder in children and adolescents, MISC. That reflects the clinical and laboratory features observed in children reported to date. Of course, the case definition will be revised based on more data in the future. About coronary artery involvement in MISC, based on our experience, fortunately, the prognosis of our patients were not bad. There was no mortality case and coronary arteries involvement were not severe, and most of them have improved after treatment. We use high dose of methylprednisolone pulse therapy for our patient alone or as a combination therapy with IVIG. And maybe this treatment is effective or better. As you know, COVID-19 infections has an effect on T cell and appears to reduce their ability to limit the inflammatory process. So corticosteroid as an anti-inflammatory drug can affect on MISC. Of course, I think we need to gather more information and data to judge the best or most appropriate treatment for this disease. Thank you.
Thank you very much. Do you prefer do you prefer the early use of prednisolone or corticosteroid, or do you prefer to treat these patients just like a typical Kawasaki, first with IVIG and then go for the corticosteroid use?
In patients with MISC,
Yes.
According to our limited experience with this disease, we prefer use methylprednisolone, high dose of methylprednisolone, because it's effective, and we think this is better than IVIG alone.
Thank you very much. Let's go to dear Dr. Rohani. Do you have any special experience with COVID-19 patients and the GI involvement? Do you see GI complications often in these patients? Dr. Rohani?
Do you have my voice?
Yes.
Okay. Hello, everybody. Thanks for your great presentation, Dr. Aghay. It's a great meeting. I want to say that, yes, as you know better than me, and study about COVID-19 infections, we have a lot of gastrointestinal symptoms. Sometimes the gastrointestinal symptoms precede the other symptoms, and then you have another symptoms, especially respiratory tract symptoms, or maybe in a little tiny of population of patients, just we have signs and symptoms of isolated gastrointestinal symptoms, but they are not a huge population of the patients. About your case, especially if I want to say that, because we know that diarrhea, vomiting, nausea, vomiting, or abdominal pain are the most common manifestations of COVID-19 GI symptoms in adults and in children. Limited data are, as you know, are not enough to say, but this distribution of the symptoms between adults and children are the same in GI symptoms. But about the other involvement, I want to say that, you know, we have a transaminitis in patients with COVID-19 infection, especially AST, ALT elevation, but sometimes more. And because we have ACE receptors on both cholangiocytes, pancreas, or any other parts of the GI from esophagus to, you know, colon, we have many receptors, and we believe that these receptors helps the GI tracts to be involved in these kinds of patients. Anyway, about the pancreatitis, especially in your case, if I want to say, elevated amylase, lipase, both of them shows that the patient's pancreas may be involved. But if you look at the other studies all around the world, just we have one report with 2 or 3 persons in one family with pancreatitis and COVID-19 infection. And the other studies, especially US studies that I studied today, just they had 12 persons of the patients that with elevated amylase and lipase, but no signs and symptoms of pancreatitis in the patient, especially as you see in the CT scan. Of course, Dr. Mehtizadeh will help us in that purpose, but just we had in this patient elevated lipase and amylase, and this is not, you know, exactly the same as we say that our patients have pancreatitis. Generalized abdominal pain in this patient may be because of the vasculitis, because in a KD disease, in KD patients, we have vasculitis, and this vasculitis is the main reason of the abdominal pain. Is this as your patient have generalized abdominal pain, and I believe that vasculitis is the main reason. And if you have any more questions.
Thank you very much, Dr. Rohani. There was so many good points in your speech, and I really enjoyed those points. So let's go to Dr. Mehtizadeh. Do we have Dr. Mehtizadeh with us?
Yes, I'm here.
Hello. Dr. Mehtizadeh, are you aware of any special radiographic findings that can be related to the severity of the COVID-19 infection? Do you think the abdominal CT scan in the severe forms of COVID-19 should be done?
First of all, hello to everybody, and thank you so much for inviting me to this webinar. As you noted, there's only bilateral pleural effusion, and I don't find any sign and any source for abdominal pain in this patient. No evidence of pancreatitis, no evidence of bowel loop thickness or thickening, and no evidence of thrombosis or any sign of ischemic disorder. And only bilateral pleural effusion in CT scan you can see. But in chest X-ray, it's absolutely normal. And you cannot see even pleural effusion in this chest X-ray. And I don't find any sign of COVID-19 and no aerospace consolidation, no patchy infiltration, no atelectasia, and absolutely chest X-ray is normal. And only I find bilateral pleural effusion in CT scan.
So you are not aware of any special radiographic findings related to the severity of the COVID-19 infection, yes? I'm not aware of them too. I think we do not have your voice, Dr. Mehtizadeh.
Have you?
Yes,
have you
yes.
As I noted before, there is no sign of COVID-19 in chest X-ray and abdominal CT, even bilateral pleural effusion.
Thank you very much. So let's go to Dr. Gharib. Dear Dr. Gharib, according to our previous experiences with the severe cases of Kawasaki diseases, do you believe is there any special point that we should be aware for the critical patients with Kawasaki diseases and also for the patients of Kawasaki-like disease with COVID-19 patients, especially those who are admitting in the ICU? And do you believe they are going to have multi-organ failure? Are you aware of any cases that had MOF in MISC?
Good evening, everyone. Thank you for having me and for the nice conference. Yes, it has been reported all over the world that MISC can lead to multi-organ system failure like Kawasaki disease and other multi-system inflammatory syndromes. We know that since 2009, Kawasaki disease shock syndrome has been described. And when we admit a patient in intensive care, for whom those who have been admitted in intensive care unit and we worry about their clinical deterioration, a close observation and monitoring structure should be performed. We know that any subtle change in vital sign or changes in physical examination can be a warning sign of a coming critical event. And the healthcare team should do everything not to get behind of the critical condition. Otherwise, the disease will overtake us. The healthcare that has been trained and experienced in emergency and intensive care know that they should regularly and timely do physical exam and check the vital signs, which they can be the warning signs of the coming event. Any changes of the patient's condition should be noticed and need a proper intervention, and all the conditions should be predicted. Because, for example, if you have a child with cold extremities and a fast heart rate, it could be a warning sign of shock state. And if you have this patient when the blood pressure has dropped, in this case, maybe we are too late for bringing back the patient and reverse the critical condition. Some signs, some warning signs has been mentioned in the guidelines. For example, worsening of the fever, cardiorespiratory deterioration, worsening of neurologic symptoms, and some lab data like rising ferritin, unexpectedly low and falling ESR, rising fibrinogen, or low fibrinogen at rising liver function test and rising the dimers, and changes in electrolytes, or extending rash, or worsening gastrointestinal symptoms has been mentioned as signs of worsening inflammation. But apart from that, as a routine, we in the intensive care unit, we check our patients and examine them from head to toe several times a day in order not to get behind of the event. We check, and the physical exam is much more important than the lab data, because the lab data are subject to error, and they are subject to technical error and interpretation error, and we may not have them on proper time, we may have them late. But it's easy for the trained eye and hand to, in a few minutes, in 1 or 2 minutes, detect the coming critical condition and react to reverse the situation. We check for vital signs regularly. We check for consciousness, level of responsiveness, rare presentations of a seizure. All of them could be signs of deterioration of nervous system. We check respiratory rate. It's very important to show us the metabolic rate of the patient, and the respiratory effort can be a sign of progressing respiratory involvement. We check the cardiovascular system by checking the blood pressure, capillary filling, the temperature of the extremities, peripheral edema, and also for some lab data could show us there's a condition of cardiovascular system. For example, rising levels of lactate and hyperkalemia could show us that the cardiovascular system is not working well. We check the kidneys by the level of urine output, because we know that changes in urine output not only reveals the hydration condition, but also the efficacy of cardiovascular can be assessed by the level of urine output. And hemodynamic changes, any subtle change, should just be identified by regular exam, and being very serious about not ignoring any subtle change. The size of liver and spleen also has been mentioned as important signs of deterioration of these multi-system inflammatory syndromes. And also the lab data is very important. We should be aware of changes in, as I mentioned before, the changes in ferritin, fibrinogen, the dimer, blood cells, and electrolytes should be noticed. Changes in oxygenation and ventilation could be the signs of deterioration in cardiovascular and respiratory system, and maybe needs proper and fast reaction. So it doesn't differ from the critical situation in other diseases. All of these patients who we are worried about their sudden deterioration should be checked regularly in the intensive care, and all of the systems should be reviewed several times a day. As we because otherwise we will left behind, and it's very difficult to follow a patient that is deteriorating quite fast.
Thank you very much, Dr. Gharib, for your educational points. Let's go to Dr. Abdesalehi. Dr. Abdesalehi, in these cases, the cases of MISC, should we go, in your opinion, should we go for the more aggressive therapy than the typical Kawasaki disease? Should we go for the combination therapy, for example, IVIG and corticosteroid from the beginning of the therapy, or should we just wait for the signs to come? What do you believe?
Good evening, everybody. As you know, most COVID-affected children are asymptomatic or only have mild symptoms. In the previous 2 months, a small number of children have been identified who develop a significant systemic inflammatory response, such as the pediatric shock and Kawasaki-like syndrome. Affected children may require pediatric intensive care units and input from pediatric infectious disease, cardiology, and rheumatology. Some clinical symptoms of Kawasaki disease and COVID-19, such as fever, rash, and eye redness, are common and also present in many other childhood illnesses. However, the lab results of these two groups of children seems quite different, and in particular, the children with COVID-19 infection have inflammation of the heart muscle rather than involvement of the coronary arteries in Kawasaki disease. The pediatricians should immediately refer any patient who seem to have a MIS syndrome to a specialist in the pediatric infectious disease and other subspecialties. Early diagnosis and treatment of patients meeting full or partial criteria for Kawasaki disease is critical to preventing end organ damage and other long-term complications. IVIG is a good option in MISC treatment, as MISC has a lot of clinical features that are common with Kawasaki disease, and it has anti-inflammatory action. And also IVIG has a promising effects in COVID-associated severe pneumonia and ARDS in intensive care unit. So it depended on the intensity of the cases, and treatment with IVIG or corticosteroid should be individualized with consultation of pediatric infectious and rheumatology. It seems that in severe cases, both medication can be tried. For knowing the best treatment, we should wait more the results of the trials. Thank you very much.
Thank you very much. I also have a question. Any of our colleagues can just respond to these questions. If we use corticosteroid with the active COVID-19 infection, is there a danger for the spread of the virus more severely? Is there any danger for that, or you believe the corticosteroid will help with the inflammation of the COVID-19? Can you answer me, any of our colleagues?
It is a dependent situation of the patient. In the MIC is a critical for patient, and very damage in the multi-organ in patient, and maybe die in child. Therefore, depended may spread viruses, but but uh, but the critical patient exactly treatment.
So you believe that we should go for the corticosteroid treatment in the critically ill child against the danger for the spread of the virus, because the patient is very critical and the multi-organ failure of because of the inflammation is more dangerous for the patient than the virus itself. So finally, I want to go to Dr. Sayadpour, my dear friend. Can you just have a quick review of the definition of MISC, can you review the cardiac involvement of this etiology for us?
Hello, everybody. First, I want to thank Dr. Badran for the great presentation and for the acceptance of our invitation. The cardiac involvement in MICS, I prefer to tell it MISC. The cardiac involvement in MISC, the coronary involvement in the reports is rather like the classic Kawasaki disease. Around 20 to 25% have coronary artery dilation. But there are also involvement of the pericardium with pericardial effusion, myocardium with low ejection fraction, and endocardium with valvular regurgitation, especially mitral regurgitation. And totally, if we consider all of them, the risk is much higher. In the Italian report, it's around 60%, so much higher than the classic Kawasaki disease, if we put all of them together. But for the coronary involvement, it's just like the classic Kawasaki disease. And what I see in Iran, in our cases, the risk of toxic shock, like or maybe low EF and hypertension, it seems to be lower than what there is in the reports from Europe and US, I think. As far as the small case that I know, the risk of hypertension and low EF is less than in other reports. Thank you.
Thank you very much, everybody. There's only one question that is asked from our panelists. One of our friends asked, is there any contraindication for IVIG in MISC management? Dear Dr. Tahiqi, are you with us?
Not really. IVIG and corticosteroid advised to treatment for MISC. But according to our experience, we used high dose of corticosteroid in our patient, and it's better.
Okay. Thank you very much, everybody. I would like to thank all of our panelists and all of our guests, especially Dr. Badran. It was a very great honor for me and for my colleagues to have you from LA. And it is a very nice view behind you. And I wish you a very nice day. And maybe we will see you again. Thank you, everybody. Have a good night and day. Bye-bye.